highlighted them throughout. And I will, we'll try to go slow. Usually I do face to face, so we would have, it would be more interactive. But we'll make this as fun as we can. I'm going to skip several of these slides just to keep it. Over the years, I've built such a large presentation that I'd be skipping slides that are no longer relevant. So let me start with this. You read about class 1, class 2, class 3 guidelines and so forth all the time, but this is actually sometimes tested on the boards. They would basically give you a recommendation. They'll word it as in, this that the ACC recommends beta blockers as a class 1 for patients with CAD, and they'll ask you to choose what that means. Or they would say that multiple studies have shown a significant benefit with beta blockers in patients with CAD in terms of mortality and so forth. So what level of evidence does this suggest? So class 1, as you know, that's easy. Benefits far outweigh risks typically based on multiple randomized controlled trials. Class 2A and 2B are kind of similar. Class 2A is where there is a definite benefit and it is reasonable to perform the procedure or the intervention. Class 2B, on the other hand, is perhaps there's a benefit, it may be considered. So it's a little less strong. And class 3, as you know, is contraindication. So know this well, it's easy pickings. And then in terms of the level of evidence, you have levels A, B, and C. Level A evidence suggests that there are multiple randomized controlled trials in multiple populations that have been evaluated. Level B would be typically just one single randomized controlled trial done in a limited area of the globe. And level C is where just no randomized controlled trials, usually case reports, case studies, and so forth. And if, in the interim, if you have any questions, please shout it out. I don't have access to the chat box here, so you'll have to speak. So moving on, I just have some chest x-rays. These are basically chest x-rays pertaining to cardiology that have been asked in the boards. For the most part, you would have enough clinical information that'll make it easier for you, even if you don't identify the x-ray itself. But we have a few here. Let's go over these. So as you can see here, this is typically a normal size heart. This would be someone who is coming in with, shortness of breath, maybe elevated JVP, who has a history of typically some kind of lymphoma, received radiation, and so forth. You can see the lung fields are pretty clear, and you can see this pericardium kind of prominent, calcified, at least on one side. In the lateral view, you can see it much better. So this would be typical of constrictive pericarditis or just constriction. Next one, this is again, we seldom ever see these anymore. This is a typical rib notching seen in patients with coarctation of aorta. And you can see what this is called a 3 sign right along the border of the aorta as well. It's something that's good to know. It's pretty prominent. You'll have a good history of someone with a murmur and severe hypertension or elevated blood pressure in the arms, lower pressure in the lower extremities, and so forth. So this is easy, again, easy pickings here. It's a large heart, typical of pericardial effusion, someone with a tamponade, typically someone with, dialysis or a viral infection coming in with sudden hypotension and shortness of breath. So this is another one. I don't think it's been asked in the last few years, but it's good to know. This is a typical chest x-ray from someone with mitral stenosis. So which is typically rheumatological condition. We don't see young female in her 20s, usually pregnant, coming in with shortness of breath. And you can see in this chest x-ray, very enlarged pulmonary arteries. That's pretty typical, and an enlarged right ventricle. So this is only seen in some congenital conditions or mitral stenosis. So we just went to
Dr. Russo, I think we lost you sound-wise.
Nope.
Oh, now we can. I don't know if it was just.
So I'm using the built-in microphone. Let's see. All right, let me know if it doesn't work. It should.
You're good now. I'm not
Okay,
sure what
all
happened,
right.
but you're good now.
All right, good enough. Let me get to the talk. So physical exam findings, it seems kind of daunting, but usually it's just a lot of verbiage. If you don't quite get it, then you can just move on to the rest of the question. You'll usually get the answer. These are some of like the bullet points. As you know, the aortic valve is typically louder and closes first. If it's soft, it's typically aortic stenosis. A soft A2 or absent A2 is aortic stenosis. And if it's delayed or reverse split, it's left bundle branch block. So these are just certain key words to remember. Reverse split A2 is always left bundle. A loud P2 moving on is typically pulmonary hypertension, and a soft pulmonic sound is PS of pulmonary stenosis. A delayed P2 where the right side closes later is right bundle branch block and RV overload. So some of the split heart sound, it's because we really rarely ever use it or learn about it during our residency. Just a few words about it. So typically, the right side of valves open earlier, they close slower because it's a low pressure system. It takes some time for them to open, and for the same reason as well. Now, normal splitting is where the P2 closure is always delayed during inspiration because there's more inflow into the right side. So that's what causes splitting. And when you're breathing in and out during inspiration, it's going to be delayed further. So when do you see persistent or widened splitting? Typically, again, right bundle branch block. Fixed splitting, again, it's come up in splitting. It's septal defect, ASDs. Paradoxical splitting, where the right side closes earlier, usually left bundle or pacemaker. Because pacemaker is essentially a left bundle branch pattern. So heart sounds, again, if you see a loud S1, there's just one condition, mitral stenosis. A soft S1 is typically atrial fibrillation because you barely hear S1 in AFib. Opening snap, again, mitral stenosis. So remember these keywords. I'm going to skip this slide. Actually, no, let me go over this briefly because they always give you where the murmur is located. So if you hear something that's inferior to the left clavicle, it's PDA. It's called a continuous murmur or a machine murmur. Anything in the left second upper intercostal space is the left side is usually pulmonic, and the right side is aortic. And if it's at the apex is mitral, so that's just the location of the valves. And the lower sternal border is usually on the right side is tricuspid regurgitation. So that's usually what you get. Tricuspid stenosis is so rare, you don't need to worry about it. So just remember that in the upper part of the sternum, the right is aortic, left is pulmonic. On the lower sternal border, right is tricuspid. On the left side, usually it's the apex, it's mitral. So those are kind of the broad locations for where the murmurs are. So in physical exam, they always tell you about these maneuvers where you make the patient stand or do a Valsalva. Just the basic physiology behind these. If you make someone stand up, their venous return decreases. So most regurgitant murmurs decrease when the volume of blood decreases. The exception here is mitral valve prolapse and Hookham. So hypertrophic cardiomyopathy needs volume to separate the ventricles out. So if you have less volume, there's more obstruction, so the murmur worsens. Now, if you make someone squat, it increases your afterload as well as pushes blood back into the heart, so your venous return increases. So almost every murmur worsens except for Hookham. because when there's more volume, it separates out the outflow tract, the LVOT, and there's less murmur. Hand grip is the only maneuver that can help you differentiate MVP and hook'em. When you increase the afterload, the MVP murmur actually increases because the mitral regurgitation increases, whereas hook'em decreases. Okay, moving on here. So if you hear a diastolic murmur, there are 4 choices. In the upper sternum, it's either AI or PI, depending on the location. On the right of the sternum is AI, left is PI. Lower sternum, it's either mitral stenosis or a PDA is usually, patent ductus is often below the upper sternum or below the clavicle. And systolic murmurs are typically AS and MR. So if you hear a blowing murmur, it's usually some regurgitation. Crescendo, decrescendo is aortic stenosis. And the diastolic rumble is mitral stenosis, usually. And if you hear the words like vibratory or, float, anything that's soft, left lower sternum border, musical murmur, those are all just flow dependent still murmurs. It's a benign condition. It's normal, seen in most young people as well as pregnant women. That's still murmur, okay. I'm just going to skip this. This was just a question and answer session. Since we are on Zoom, we can't really do this. So let me just move on. Again, the key words with pulse, anything bifid pulse is hook'em or severe AI. Pulses alterance is CHF. Again, these are the key words. You just have to connect the two. Slow rising pulse is usually aortic stenosis. And you all know pulsus paroxys, usually tamponade. So some of these were just question and answer sessions. I'm just going to kind of breeze through these. So venous pulse, this is also good to know. This diagram is out, has been shown in the boards a few times. So just know this kind of what a pulse looks like. A venous pulse, again, typically it's ACV. A wave is where there's atrial contraction. C is where the tricuspid valve closes, and V is the just a passive venous filling. On the X decent and the Y decent. The X decent follows the A wave, and Y follows the V wave. So there are 4 possible conditions that can be associated with this venous pulse. First is a Canon A wave, where the A wave is just peaks very tall. This happens when the atrium contracts against a closed tricuspid valve. Usually seen in, it can be seen in VT or with pacemaker. So if you see a Canon A wave, it's complete heart block, VT, or a pacemaker. Now, constriction and tamponade, both of them again have some typical venous pulse patterns. You see a prominent Y decent in constriction and a prominent X decent with tamponade. So if you have someone with a similar clinical presentation and where this X is just comes back, it's very steep X decent, or they'll usually describe that to you. You just got to remember X is tamponade and Y is constriction. And you all know the small sign. So CHF, if you push up the liver, you'll see the total volume of the whole venous sign. So these are some things to remember. This is an example of what
Dr. Rossi, I think you're cutting in now a little bit again.
Oh, really?
Oh, that's better.
I don't know what's okay. All right, let's keep going here. So again, these were some questions that have been asked in the boards before. So sharp, irregular Canon A waves, the white complex tachycardia, that would be typical of VT. So SVT would be a nerve complex with intermittent cannon A waves. So this happens because the atrium is beating faster than the ventricle. So for some beats, the tricuspid valve is open, and others it's not. So where the atrium beats against a closed tricuspid valve, you'll see a cannon A wave. So that would be SVT. We just talked about the steep Y descent is constriction, and X descent is tamponade. So these are. So I just have a few more questions here. Sorry, went back to the old slide. So some more questions. Again, these are I know these are questions that were emailed to me by the residents after they take the boards, so whatever they remembered, mostly cardiology fellows. So 65-year-old white male with JVP 4 centimeters supine, 10 centimeters while palpating the liver. What's the diagnosis? Again, we talked about it, small sign CHF. 30-year-old female with a loud S1, a loud P2, mid-diastolic murmur with presystolic accentuation. This is typically mitral stenosis with some pulmonary hypertension. 60-year-old male with ESRD presents with acute dyspnea, elevated JVP, clear lungs. So when you see elevated JVP, clear lungs, it's usually tamponade or constriction. When you see ESRD, these patients end up with uremic pericarditis and end up with the tamponade. So that's typically syndrome. So it's mitral valve prolapse with regurgitation. So 18-year-old with palpitations, 2/6 systolic ejection murmur along the left sternal border, decreases with Valsalva. So it's a flow-dependent murmur, left lower sternal border, and has typically a still murmur at the demand condition, has nothing to do with the palpitation. Again, so they do, we rarely ever do these anymore, but
Sorry, same situation again.
so maybe can we just reschedule this? If it's not working, maybe I could do it from my office. That might be better.
Whatever works for you, Dr. Restu. I think we can hear you now. I'm not sure if it's just
Yeah,
the microphone source is, if it's cutting in and out.
Yeah, I'm not sure what it must be my laptop, I guess, or the internet in my house. I apologize. I think we can do it better from the from my office at the VA.
Okay. Whichever works for you.
Yeah, let's do that. So, but you guys are not doing any of these face to face, or these are all just
We're unfortunately all virtual this year, just out of like resident schedules and.
Gotcha. Okay.
Yeah.
So why don't we, let's try this out another day from my office. I think that might be better.
Okay. Well, sorry for being on Zoom. We'll coordinate another.
Okay.
Doing this again. Okay.
Sorry about this.
No problem.